Hello, my name is Christopher Sweeney. I'm from the Dana-Farber Cancer Institute, and I have the great opportunity to present the results of the ENZAMET study on behalf of ANZUP, Canadian Cancer Clinical Trials Group, Cancer Trials Ireland, the Clinical Trials Centre, a global academic collaboration which asked whether enzalutamide, which we know prolongs survival and works in the castration-resistant setting when men are having disease progressing with a low testosterone, asking whether a drug that works there, enzalutamide, has even a greater effect when we start it in the hormone-sensitive setting. So we randomized 1,125 men to testosterone suppression, starting for their hormone-sensitive prostate cancer, starting therapy, to enzalutamide or a standard non-steroidal like bicalutamide, for example. We also allowed patients to get docetaxel concurrent with the non-steroidal first-generation agent or the enzalutamide. We also had patients with a high burden and a poor prognosis, and a low burden and a better prognosis. And what we found out is that the enzalutamide prolonged overall survival, and the signal was very, very clear in patients who didn't get docetaxel. It was less clear in those who got docetaxel. What we see in both settings is that there is a delay in the progression. So now I see these results, I will sit down with patients and say, you, Mr. Smith, for example, I look at your scans and you have a high burden of disease, and I know in this setting docetaxel added to the testosterone suppression works. I know adding enzalutamide, apalutamide, and abiraterone work in this setting too. And these are the side effects, and these are the costs and the benefits of both approaches. Chemotherapy, you're done in 18 weeks on testosterone suppression, and you could possibly get these agents at progression. The ability to get these agents at progression may be the reason why they're not getting the survival benefit at this early stage, because they get salvaged with the active therapy at progression. So A plus B and stay on A plus B doesn't seem to be better yet that we can tell of A followed by B. However, if you're not fit for chemotherapy or you have a better prognosis, it's clear that testosterone suppression plus any of these drugs, abiraterone, enzalutamide, apalutamide, improves your survival. Which agent to choose depends on what ones can be accessed through healthcare financial issues, but also the patient's health. If they're diabetic, we'd want to steer away from the prednisone needed with the abiraterone. If they have a seizure, we want to steer away from the enzalutamide or the apalutamide. So it's a decision based on the patient and the physician having a conversation, looking at their scans and looking at what their preferences are.